suggest that if we have any questions from the audience, go ahead. Professor Gottesman, please. First, we are using it, and I'll tell you a little bit about how it evolved. The test in most of the paper has been done with ELISA, which is much more difficult to do when you want to do it to many patients. Then there was a kit developed that you could use it with a regular, how would I put it, with the automatic machine in your lab, and that was very simple. Unfortunately, although this kit has an FDA approval, when we tested this kit, we recognized that this kit is actually not giving you an accurate results. We went back to the company and they withdrawn the approval from the FDA. Actually, they sent a letter to the FDA that there was a mistake and we don't have this kit anymore. So we had to set up an ELISA test that you can test hundreds and thousands of patients. And we did so far in one center in Israel because we don't want to give non-accurate results. And we start doing this test right now at the Sheba Medical Center. The idea is that at the end of the day, we should have about 4 centers where we're doing. One in Jerusalem, one in the north, one in the south, and one in the center of Israel. And the reason is because it's a very tricky test. And even with the HMOs that considering now using this test, the idea is that we won't have 10 or 15 different labs. It's quite complicated. And before that, in the time zone when we couldn't use the kit and we had to do the ELISA, instead that's Germany. Because otherwise you get numbers that are not accurate. And that's why it's costing about 400 to 500 shekels. I'm sure that we are going about 5 different labs that will do it in Israel. It's not complicated because you need anyway to freeze the sample before you do the test. So it's quite easy to freeze it and then you just ship them and you do the test. We start doing it in Israel and we're doing it now to thousands of patients. Nathan, maybe you can elaborate more about how to do it.
We hope that we'll be able to use it in neurology. I think that in neurology, as you've mentioned, we have several conditions where we need to find the biomarker for what we call vulnerable plaque. We have patients with incidental finding on carotid Doppler with asymptomatic carotid stenosis that we still don't know whether or not they should be submitted and exposed to operation or stenting, which is still a controversial issue. However, had we had a test to show us that actually this particular plaque is vulnerable and has a higher risk than the average, we would be very happy to use it as a biomarker. The same applied to intracranial atherosclerosis. We thought previously that is only a disease of the Asian Pacific people, but we currently know that it's more and more common in our population as well. And again, we don't know what to do and how to treat this patient, and whether this stenosis intracranially is vulnerable and carries high risk for stroke. There are some other patients that we do CT scan or MRIs and we find what we call silent brain infarction. These are patients that are at high risk for stroke, but we cannot identify how to treat them and whether we should treat them more aggressively than the others. This small vessel disease is endothelial dysfunction disease. One of these endothelial dysfunction. As you mentioned, this is the test that we can test for endothelial dysfunction. So I think in neurology there is a place for this test, and I think that we could use it more widely order to identify the subgroup of patients where we can treat more aggressively on one hand, or justify surgery or intervention on the other.
Thank you. Professor Brownwell, maybe you want to say something as you are leading one of the big trials here. There's no comment. Okay, any other questions? That's a very good question, and I will repeat the question because it was without a microphone. I was asked what are the levels that we do call as a high level, and if someone do it in his own lab, would you get different levels? So it has to be a validated test, and therefore we're doing it only with a very specific ELISA kit, and you do need to do it in a very specific way because otherwise you do get different numbers, and then you cannot really correlate it with the studies that has been done. It is well accepted right now that with a standardized ELISA that we are using, below 200 is within normal limit, above 215 is a high level, and in between is a gray zone. And as I was saying, if you get 250 or 400, it doesn't really matter because the patient is at a higher risk. But again, I'm saying, for research, one can use it with simple ELISA kit in his own lab, but you will see that the variability is quite difficult unless you do a very thorough way using control samples. So I don't suggest that we'll just do it for the clinic in every lab. So right now the situation is that we can have this test in Israel. It can be sent from any center around Israel. It's basically, the cost is not that high, and usually it can give you a very good predictivity on the activity of the plaque in your patients.
Just want to add that basically for the stroke, it was shown that there is incremental or additional value for the test above and beyond the regular assessment of risk for stroke. You know, the Framingham and the others are basically were established for coronary artery disease. For stroke, there is no established particular risk stratification, and therefore I think that at least for the study that was conducted in stroke, it was shown that above and beyond the blood pressure and cholesterol, again, it's not a very good predictor for stroke because blood pressure is the major risk factor for stroke, and therefore above and beyond the regular common vascular risk factors like blood pressure, this test was shown to be very useful. So I think that we should at least study it more in this particular aspect to see whether there is incremental and additional value for this test in vascular diseases. And vascular, because it's not just stroke or heart altogether.
Betavon, bon appetit. We let you eat without us talking. Thank you very much.